Welcome everyone to the Baker Institute. If you haven't been here before, my name is Vivian Ho. I'm a health economist and director of the Center for Health and Biosciences. I just came to introduce our latest newest scholar, Dr. Keonta Moore, who has organized this event for us today. If you know me, I mostly sit behind my desk and crunch large databases on a computer, trying to say things about healthcare policy. And we realize that doing effective healthcare policy requires many different types of approaches, which is why we asked Dr. Moore to come join us at the Baker Institute. Even though I'm sort of sitting in my office analyzing large databases, Dr. Moore takes a completely different approach and really gets out there in terms of the community and trying to assess what the needs are in terms of improving the public's health. And that is the approach that's definitely necessary in the areas that she's working on in terms of improving children's health and in terms of tracking what's going on in terms of telemedicine in the country today. It's such a fast-moving industry. So with that, I'm going to get out of the way, and I'm going to hand things over to Dr. Moore. Thanks.
Thank you, Vivian, for that introduction. So today we're going to talk about telemedicine in school, improving access to health care. In the state of Texas, we have approximately 7 million children. Of that 7 million, 25% of those children live in poverty. Poverty increases the incidence of chronic disease and illness in that population, and also increases utilization of healthcare services. Additionally, 16% of all high school students are obese. And between 2 and 4-year-olds of low-income children, 15% of them are obese. Asthma is also a huge problem in our state. 500,000 children in Texas have asthma, and asthma-related exacerbations is the top reason for hospitalizations in young children. Chronic disease and illness in childhood leads to increased number of missed days of school and poor academic performance. Moreover, untreated or poorly managed chronic disease in childhood leads to worse health outcomes as adults, which also increase costs. So I've painted a grim picture here, but there are people working in our state in order to improve childhood health in Texas. And one of those ways is through the innovative use of technology. Telecommunications is one solution to improve healthcare access and hopefully health outcomes in areas that we need them the most. Telemedicine is one of the telecommunications. So telemedicine in the state of Texas is defined as using telecommunications in order to provide healthcare services. And one of those providers has to be a physician or a licensed healthcare professional operating under the license of that physician. Telehealth, on the other hand, which is also a commonly heard term, in Texas means something different. So telehealth in Texas is really the delivery of health care or provision of health care service via these same telecommunications, except the health care provider is not a physician. They are a nurse practitioner or a lower level person, a lower licensure person as a counselor, et cetera. And the definitions of these two uses of telecommunications to improve health really has an impact on reimbursements in our state. But for today, we're going to focus on telemedicine and how telemedicine can be used to increase access to care. Telemedicine also is used currently in our state to provide consultation services. So in areas of rural areas where community physicians may not have access to large medical centers like our Texas Medical Center here, they can access specialists when they have questions or treat patients with more complicated healthcare needs via telecommunications. It's also a way to provide healthcare education for patients. So there's several initiatives around our state where telecommunications are being used to provide and educate families and parents about their healthcare needs. And also education for providers. Providers constantly need, medicine is ever evolving and changing, and the science is ever evolving and and changing. And so physicians need opportunities to increase their learning, and telecommunications is an effective way to do that. Today we're talking about connecting children to healthcare, though, through telemedicine. And access to care, unfortunately, in Texas continues to be a problem. So as the latest policy report by the Center for Public Policy, 1 in 8 children in Texas remains uninsured despite implementation of the ACA, and also despite opportunities for Medicaid and CHIP enrollment. Our speaker today is going to talk about ways to increase access to care for low-income children, particularly those who are insured by insurance, through her recent bill, House Bill 1878. So with that, with great pleasure and a warm welcome, I'd like to introduce our speaker, Representative Jody Laubenberg.
Okay, let's see. Can y'all see me? I normally don't like to stand behind a podium. Oops, let's see. Okay, I normally don't like to stand behind a podium because, for obvious reasons, they don't have the little step for me to stand on behind the podium. But I'm going to do my best, but I need to follow my notes because I tend to get off on rabbit trails, and I know your time is limited, and I would like to have some time for questions if that's okay too. So I'll give my presentation, and I appreciate y'all being here. I know there's weather in Dallas and it's moving up here to Houston, so coming is definitely a big deal, plus also getting in traffic. And as Dr. Moore said, age of technology. And I began, when I graduated from UT, I know I'm at Rice. My husband actually went to Rice, so I have a little claim here. But I went to work in the computer industry before the internet, and it has so far left me behind. And now folks are dragging me kicking and screaming into technology, social media, and so being in politics, you have to do that, all of that. But what did excite me is how technology is helping in the medical field and helping with affordability and accessibility. We talk a lot about having affordable health care and having access to high quality health care. But what exactly does that mean? And so the telemedicine, to me, is a market response to that need. And today, as Dr. Moore said, we're going to focus on kids, children, and telemedicine. Telemedicine has been around for a long time. UTMB actually has used it for years with the prison system, and also telemedicine has been used in the senior care nursing home settings. But telemedicine for children is actually a new concept. And I'm also going to highlight Children's Hospital in my talk today because they were the ones that actually brought me 3 pieces of legislation. I have carried telemedicine legislation in the legislature in the past, but these were 3 bills that they brought specific for children's telemedicine health care, and I want to talk a little bit about that. Out of the 3, 1 was passed, and since a lot of you are policy wonks, I will tell you the story behind that one so that you can be thinking about that. You think, well, this is easy, no-brainer, telemedicine, children, who would be against any kind of legislation for that? Well, you would be surprised. And also to define, as Dr. Moore said, there's different definitions of telemedicine, telehealth, telemedicine. Nothing is as simple as it seems. And you hear a lot about teledoc. This is very different. Teledoc, and you'll hear some folks that are saying, well, we're not real comfortable with telemedicine because of the whole teledoc thing. I'm not going there today, but just to give you the difference, teledoc is actually not a face-to-face. It can be, but it's the telephone call. What you used to do many times with your physician, you'd call them up, hey, I've got a rash, something's going on, they prescribe you something. They can't charge you for it. Teledoc takes it down a new avenue to do that, also allows you to talk to a doctor that's not necessarily your primary care physician. We are not talking about that today. Telemedicine, in the case of my legislation, House Bill 1878, is a face-to-face. And so basically, telecommunications, information technology, they're opening the doors to innovation and changing the way that we deliver health care. Health providers are increasingly able to provide care outside the hospital walls, outside the doctor's offices, in places where you live, where you work, where you play, and now where your kids go to school. With the use of computers and a secure two-way video, and again, very different from the teledoc, the two-way video, a school nurse can now connect a student. Oh, Dr. Moore, we had a video. I'm sorry. Can we do that first? I'm getting ahead of myself. Let's do a restart. I apologize.
The technology that we originally used to treat astronauts in the space program is now a tool that can be used to help parents keep students present, healthy, and ready to learn. That technology is called telehealth. The majority of parents work during the school day. For this reason, it's not always easy to make last-minute schedule changes and life changes to accommodate a child who is at school with a minor illness.
In a working class community, taking off for my job again means that it impacts my entire family financially.
This is where telehealth comes in. If a child becomes ill during the school day, telehealth allows the child to see a doctor without ever having to leave campus.
Child can be seen at the school. You can participate by telephone if the parent elects, and they're being seen by a doctor or a nurse practitioner.
The child is referred to the nurse's office where the telehealth device is present. Using a secure connection line, a school nurse calls the doctor.
Dr. Thomas?
Yes, Terry.
We have a little patient here by the name of Jordan.
Hi, Jordan. Hi.
Through the use of special high-tech camera and audio exam equipment, the doctor can listen to breathing sounds and take a look at the child's ear, nose, and throat with the same ease and clarity as if being right there in the room. The doctor completes the exam and issues a treatment recommendation.
And if they'll just have Mom updated on the plan and have her pick up the medicine on the way to the school.
It's a very good thing because you don't have to be sitting hours at the doctor, not take time off of your work, just sitting hours in emergency.
We believe telehealth is one way to prepare children to see their dreams become reality. It starts right here.
Okay, thank you. I'm visual, not audio, so this kind of gives you an idea of what is actually going on. So, as I said, computers, two-way video, the school nurse can now connect that student with a physician or nurse practitioner via telemedicine, and Mom and Dad have the option of listening in on the phone. The service keeps the children in school, allows the parents to stay at work. What is the number one expense when you take your child to the emergency room? It's the emergency room cost for a minor illness. But telemedicine allows that child to stay in the school setting. Mom, Dad, they don't have to lose time at work. They can stay at work. It also provides additional educational opportunities for school health professionals. It saves the health system money by improving health outcomes, reducing costly after-hour visits to the emergency room, and cost of wages to Mom or Dad having to leave work. Telemedicine improves access to health care, and increases the resources that the school has in its setting. They have more access to more sophisticated equipment, and they're able to treat the child in a much higher level than just, giving them an aspirin or feeling the forehead. Care, what's the benefit for families? Care in a familiar environment reduces school absences. Again, as I said, allows the parent to remain at work. It provides convenient access to primary care. And again, let me emphasize how it can reduce the emergency room visit for non-emergency conditions. That is the biggest cost that we see. For schools, obviously, it can reduce absenteeism, which actually increases the revenues for schools, because I don't know if you know how the school finance system works, but the schools are paid for the daily attendance of each child. And when a child is out sick, and you've heard some schools where they've had flu epidemics and half the school is gone, the school loses dollars for each child that is not attending that day. It increases instructional time for students. Obviously, they can get treated at school and stay at school. Provides care, management, and education for families. And I'll talk a little bit about that. For the school nurses, it expands the reach of clinical resources through technology. It provides access to care for sick students during the day, and it offers advanced education for school health professionals. They're getting trained on how to provide the health care through advanced technology. For children who have a primary care provider, the program enhances the trusted relationship between a family and their primary care provider, because a detailed report must be sent to the PCP. And Dr. Moore, you talked about all the children that are uninsured, don't have a medical home. This can help in that direction as well. For those who do not have a relationship with a primary care provider, they may be eligible for Medicaid or CHIP, but they don't realize, or the parent hasn't enrolled them into either one of the programs. But let's just say they get sick that day at school. The nurse realizes you don't have a primary care physician. Well, part of the legislation requires that they give them the list of doctors who are Medicaid, CHIP, who accept Medicaid and CHIP, and they can even work with the nurse, or they can bring in a social worker to help that child have access to community resources that they might not otherwise know that they can get. Remember, emergency rooms are there to treat them, move them in, move them out as quickly as possible. You may have a night where I know at Children's Hospital one night they had over 600 visits in the emergency room. They don't have time to get to know that child and work with that child. Whereas in the school setting, the nurse knows the child. And maybe she realizes, on this little minor illness treatment, the child doesn't have a medical home, but the child could be eligible for Medicaid, could be eligible for CHIP. She can work with that child's parents, bring in a social worker to help that child. So as far as getting access, this telemedicine helps in that field. Telemedicine, as I said, has been around for several years, but school-based telemedicine is fairly new. It was begun innovatively by Children's Health, and I said I wanted to focus on Children's Health, so we've got some of the folks here, so I'll point them out. So if y'all want to talk to them, Matt, you'll be the point man, go-to person. Children's Health in Dallas developed a pilot program through a Medicaid waiver, 1115 Medicaid waiver, and that's a topic for another day. That and the space industry, opening up this. Since y'all are the policy wonks, those will probably be two areas that y'all might want to take another look at. They began the pilot program in 26 different schools and setting up the equipment. They have what they call the nurse's cart. It has a stethoscope, the video equipment, all the other monitoring equipment that they can monitor the ears and have the doctor look at everything. Today, the children's program is active in 57 schools and plan to expand into another 30 campuses with another 30 on the books, on deck. But they're not just limiting it to themselves. They initiated the original idea, but they have developed also a program where they're offering advice and technical support to other providers who they hope will expand the same technology, the same service into other parts of the state. You know, one person can't carry it for everyone. So the idea is to share the information, share what they have learned, share what they're doing with other providers to hopefully cover the whole state of Texas. Children's right now, they offer their program in both urban, rural, suburban, and charter schools. Lancaster, Denison, small. Tom Bean, how many of you have heard of Tom Bean? Small rural county. Texas Can Academies. Allen, Mesquite, Irving, and next year they will be active in DIS, Dallas Independent School District. Children's Hospital is demonstrating that telemedicine in schools work. They're providing primary care to children. They're averting costly and time-consuming trips to the emergency room, which is obviously a whole lot more expensive. They are connecting children to medical resources in the community. Isn't that what our goal is? And another example, children who, maybe have moved. We have a lot of folks coming into this state. What is it, 1,000 people a day moving into Texas? And they may not have a relationship with a primary care physician, a primary care provider. Through school-based telemedicine, they have an opportunity to get connected to a primary care provider. What my legislation did was two things. One, it allowed for the Medicaid CHIP reimbursement for this service. Obviously, when Children's Hospital set up the pilot program, they were not charging. But as we all know, nothing is free. The equipment, the overhead, the manpower, it does cost money. And so you want to keep this program going. So my legislation opened up the opportunity for sustainable reimbursement to keep it going. Also, before, you had to have a pre-existing relationship. In order to do telemedicine, you had to have that pre-existing relationship with the primary care provider. Well, that's, as I pointed out earlier, that's not always the case with a lot of these kids. They may not even know if they're eligible for Medicaid or CHIP, and may not have a doctor. That's why mom, dad is taking them to the emergency room. My legislation allowed a physician who is not the already established primary care provider to see, diagnose, and treat the child for the minor ailments and illnesses. Now, let me also emphasize, this is not to replace the specialist. This is not to replace that primary care provider. It is to move that child into a medical home. It is certainly not to step into diagnosing or treating complex, very serious, life-threatening medical issues. That's not what this bill is intended. That's not what the program is intended. It's basically for all the things that kids get sick with, the pink eyes, the rash, the allergy, the sniffles, and to try and get that child into a medical home and do it in a way that's affordable to the family, or to get the child enrolled into Medicaid CHIP. I mean, that is one thing we do take very seriously in the state and in the legislature. And we're trying to always figure out ways, how do you connect these kids with the medical community without it costing a fortune? I mean, obviously, we pay the cost, all of us pay the cost for the emergency room visits. This, you want to treat the child and you want to save money. So affordability and accessibility. My legislation, I believe, helped fill in that last puzzle piece to do that. So based on all that, you would think, well, gee, this is a very simple thing. I mean, you incorporate technology and innovation, you provide better care, you reduce costs to the health system, so this would be a win-win-win. Well, who could possibly be against something like this? Well, let me tell you, it's the legislature. I'll say the Texas legislature, but I'm sure it's that way everywhere else. I'm just in Texas, and I'll focus on that. As you know, putting any kind of piece of legislation together, no matter how good the idea is, it's like a maze trying to get through. And there's a lot of confusion, as I pointed out earlier, between the teledoc type of telemedicine and the video telemedicine that I proposed for my piece of legislation. I had to first build a coalition, and I did. I got the Hospital Association on board. Now remember, hospitals have the emergency rooms. They're a little nervous about releasing some of their expertise, let's just say, to another outside source. Texas statute does establish schools as a medical-based place, and so that's why you can have the school nurse. But we're taking it a step farther to actually allow schools to be part of a more sophisticated, higher level healthcare provider, i.e. connecting with, in this case, Children's Hospital. So we had to get the Texas Nurses Association on board because, the nurses are always worried, well, what's our liability going to be? What's our responsibility going to be? How will our nurses be trained in all this? So we had to convince them that the training will be there, the education will be there, the support will be there. Texas Public Policy Foundation, policy groups that, they're looking at this from the whole, the general broad, how does this issue help with, obviously, good health care, affordable health care. United Way, Conservative Coalition. I had groups from all over the political spectrum coming together. Texas Medical Association. That one was a little tough, I'll tell you. They're a little nervous about this whole telemedicine thing. They're very nervous about, and all the TMA folks out here, you understand, you know what I'm talking about. They're very nervous about losing that patient-doctor relationship. And my bill allows a patient to be diagnosed by a physician who is not their primary care provider. However, that part of the legislation requires that the parent is given the information. If they have a home primary care provider, that the information, how the child was treated at school, is sent to the provider. And if they don't have a provider, as I said earlier, they are given a list of doctors that the parent and child can call to hopefully get them into a medical home. Everything is designed to move the child into a medical home, to get that child with someone who can continue to treat them long term, so they don't keep going into the emergency room. Well, I had 3 bills. One of them dealt with the school-based health telemedicine. 2 others dealt with complex, doing home telemonitoring for children either with chronic medical needs such as asthma, obesity. Another one dealt with trying to do some telemedicine with children who have complex medical needs, organ transplants, cancer, because when those kids come down with something, no matter how minor it is, it's a pretty serious situation. And how hard is it to have to wrap them up, take them down, sit them in an emergency room? If you want to keep those children out of the emergency room, this is a way to do it. Well, I wasn't successful on 2 of the 3. So we go back, how did that third one get passed? Because I got everything through on the House side. Children's Hospital came down, they did a fabulous job. Testifying in committee, all bills have to go through the committee, then you have to get voted on, you have to go through, convincing everyone that your idea is better than the other 6,000 bills that are their ideas. I'm competing not just on the issue itself, but with everyone else's legislation, and it's sort of a dog-eat-dog situation down there. Of course, that part I do like. Y'all are the brainiacs. I like the rough and tumble fight on the floor. And so we got through the House. Well, I knew that the chairman, good person that he is, the chairman of Health and Human Services on the Senate side, good person, good friend, but he's a little nervous about all this new telemedicine technology. I get it. I'm nervous about technology too. They're dragging me kicking and screaming into these things. And he was concerned that we might be losing the doctor-patient relationship, standard. As much as I was going to try and assure him that that wasn't going to be the case, I don't think he was willing to go there just yet. So I knew that if my bills went through Health and Human Services, they were dead on arrival. So on a late Friday night, I called my Senate sponsor. Well, first I talked to the Children's Hospital, and I said, okay, we got to prioritize these bills. I think I can get one. I don't think I'm going to get all of them. Not this time. What's the number one? School-based telemedicine. They have been doing this program as a pilot program, no charge, but you can't sustain it if this waiver goes away. Okay, fine. This is what we're going to focus on. So I called my Senate sponsor, and I said, look, we've got to get this bill in a different committee. Let's try education. In the politics is what it is. You may not like it, but you got to deal with it. And when you know that, then you just work around the obstacles. So I said, all right, we don't want to go through Health and Human Services. Since it's dealing with schools, we can send it through education. Of course, we didn't bother telling a lot of folks about that. So quietly, he called the parliamentarian who assigns the bill. We didn't want to bother the lieutenant governor with things like that. We didn't really want to bother the chairman of Health and Human Services. They had a lot in their mind. So we just sort of quietly asked the parliamentarian, this is really an education bill. Can we just go ahead and get it assigned to education? Late Friday night. Sure did. Monday morning, the chairman's like, wait a minute, how that bill get in education? Oh, don't know, too late, so sorry. And so I went to the chair of education, who I came into the legislature with, and said, Larry, got a great bill in your committee. It's telemedicine. He goes, well, why didn't that go to Health and Human Services? Oh, Larry, no, it deals with school. Oh, okay. I said, it's really good. It's technology, schools, it could have gone anywhere. Oh, okay, all right. I said, I need it out. No problem. So, as I said, it passed unanimously in the House. When we finally got it on the floor in the Senate, it passed 30-1. Guess who the one was? He was a little upset, that chairman of Human Services. But he'll get over it. He'll be fine. So, that's kind of the whole fun part of being in the legislature. Taking an idea that you think is common sense, that you think is a no-brainer, things are not always as easy as it appears to be. But it is a win-win-win for everyone. It's a win for parents. It's a win for children. It's a win for the health system. It is what when we talk about trying to make health care accessible and affordable to those who are the most vulnerable, then this bill, this program, this new technology is right, is the example of what we need to do. So I appreciate y'all letting me talk about something that I'm excited about. I see Dr. Sigh over here, and think of that, if I'm looking at it right. I don't have my glasses, am I not? That's not, okay. I can't see very well up here, so I was trying to look at the Children's Hospital. I'm not going to name any more names. So, but I will open it up for questions if y'all have any, and just thank you for allowing me an opportunity to talk about something that I'm excited about. Any questions?
About that. Yeah, so we are going to pass around a microphone. So just raise your hand and someone will bring you a microphone and you can
Okay, one back there.
Yes. Are there any funding resources for school districts to acquire the initial equipment? Are there programs in place, or does the provider of the equipment just take the risk now that they can get the reimbursement?
Right. Okay, the equipment is provided by the provider. The schools would actually sign a contract with the provider. In the case of Dallas, it would be Children's Hospital. They provide everything. They provide the training to the nurses there to be able to use the equipment. So there's actually no cost to the school.
Really?
Mm-hmm.
Do the services include behavioral health?
Good question. Okay, that is a very good question. It has the potential to do that, but we did not put that in the legislation. So at this point in time, no. Good question.
Good afternoon. Can you talk a little bit about financing and reimbursement?
Exactly. Well, that was exactly what my legislation did. Is it allowed or directed Medicaid to do reimbursement, and the reimbursement is basically the same as a doctor visit, to the doctor's office. What it, saves the money on is the emergency room facility fees. And that is eaten by the hospital, the children's, in this case, the provider.
Hello. So at this point, private payers are not in the mix, or is just?
Oh yeah. Private insurers, absolutely. They tend to follow what we're doing in the Medicaid program. And so, absolutely, they are in the mix. If a child goes in, they sign permission at the beginning of school that they want to be able to access this service. And whether they have insurance or no insurance, then, again, it's up to the private insurance companies if they want to contract with the provider. It would be like another network provider.
Thank you.
Hi, thank you. Can you speak to whether or not there are differences in reimbursement rates for a chronic disease visit versus an acute care visit?
Okay. Talking about on the facilities, like, for example, going into an emergency room, the acute care clinics. Now, I know in my area, they're called, we have the Care Now clinics. I don't know what they are in the Houston area. And then you have, like, first choice, the emergency room clinics, freestanding emergency rooms. The biggest difference are the facility fees. In order to be classified as an emergency room, freestanding emergency room, or emergency room in a hospital, you have to have, y'all are the doctors out here will understand this better, but you have to have a certain level of equipment to treat every kind of condition out there. Urgent care is basically your minor care treatments, and those costs are much lower. The costs are related to the standard of equipment and overhead, obviously. I mean, you have to have a doctor 24/7 in the freestanding emergency rooms. So those are definitely higher costs. For example, you walk into the emergency room, even though you may just have an ear infection, you're going to pay anywhere, or the fee, anywhere from $800 to $2,000, depending on, where it is. You go into urgent care, probably, $150. Big cost difference, but they don't have the same equipment, which is why we want to keep the minor illnesses out of the emergency room. Yes,
so
sir.
I want to thank you for all your work in this field, because I'm finding that the enemies of telemedicine are the regulators. It's the Texas Medical Board and other regulators that are created the biggest obstacles. I mean, there's no doubt that telemedicine works. It's effective, it's safe.
Right.
The research is there. The Rochester study, et cetera. I can go on and on. It's safe, it's effective, it's wonderful. I work for a company called virtualers.com that we do telemedicine 24/7. In fact, we offer free telemedicine for the first 6 months. And the rates are like $49 per event after that. So it's incredibly cheap. And you actually call into an ER and talk to an ER doctor. But the regulators have created, I've gotten so many letters, you can't do this, you can't do that.
Well, and that is what I'm trying to do, break down that barrier.
Well, and that's why I want to thank you personally. I mean, this is wonderful what you've done. So my question is, pertaining to not just virtualers.com, but everyone else here, where are we moving? I mean, it's a wave of strength, and certainly the research is there. So the wave is there. The tidal wave of telemedicine is coming. But are regulators picking up on this? I mean, it's mindless.
Here is where I think you've got a room full of policy wonks in here, researchers.
I hope they're listening.
And I think this is a perfect study to see. You guys can dig into it and give us backup in the legislature, because you're right. It will be the studies. And let me also say this. You guys can convince the regulators that this is a good thing, this is a good direction to go. And think about this. Now, how many times you can't watch cable news or anything without some commercial coming up? Have you had a bad experience with blah, 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 call the law firm of blah, blah, blah? If there were problems with this, I guarantee you this would be a trial lawyer's mecca to sue. Another good thing to research. Have there been the lawsuits? Have there been the complaints? I haven't seen them, and I think we'd hear them. We would see the stories on 60 Minutes. So I think that is going to break it down as well. It's here. It's just like me. My daughter, really who got me excited about this was my own daughter using Doc on Demand. We were having dinner one night talking about it. She had the flu. That generation, they don't have time to sit in a doctor's office. They don't want to be inconvenienced. They want it quick. She got sick, middle of the night. Downloads that app, Doc on Demand. Had a face-to-face with the doctor. He tells her, look, I can't diagnose you specifically because I can't give you the flu test, but from all your symptoms, what you look like, most likely had the flu, called in, prescription, 24-hour pharmacy, dragged yourself out of bed to go pick up the medicine, didn't have to dress up, didn't have to do anything, went home, took it, $40-something later, whatever you said, and she is feeling a whole lot better. I'm like, okay, here you are. A lot of you are Generation X. Well, this next one is what I call the Uber generation. They are going to be using the iPhones to do everything. And us old guys, not you, me, we have got to start moving up. Government tends to be behind innovation. And that was another reason why I was excited about doing this legislation. I felt like for once we might be actually getting ahead of, where technology is going. We're not a lot of technocrats down in the legislature, but we're getting there. We're getting there.
Can you speak to how billing would be addressed for children in our schools who are ineligible to be covered by CHIP and Medicaid?
Yes. Again, if a student comes in, because the schools treat everyone, and they are not eligible, they don't have insurance, then that nurse can bring in a social worker that could help that child get connected with resources in the community. That is another one of the beautiful things about this technology and about this program.
But for that specific visit?
Yes. Yeah. They come in, and as I understand, the school has a contract with the provider. In the case of children's, correct me if I'm wrong, they're going to treat everyone. And that was another reason why you do want to be able to be reimbursed for Medicaid, for CHIP, because they are not going to get reimbursed from the state, for non-eligible Medicaid CHIP children, but that will not prevent children's, in this case, from treating that child. The beauty of it is they're treating them in a much more affordable situation than in the emergency room. And then you can bring in someone who could help that parent.
Hi, I just want to again applaud you as well for the work that you've done. I've served the last 4 years on the board of the Texas Institute for Healthcare Quality and Efficiency, and have tried to advocate before legislators of the need. Just for the audience's information, this type of activity is made progress in other states. In California, for more than a decade, employees at Silicon Valley firms have been able to go online to have virtual doctor visits. And those were contracts between the insurers for those companies and the physicians in the community, groups like Stanford Healthcare and Palo Alto Medical Group. So in Texas, we have a ways to go, but your work has accelerated us, and applaud your work, and we'll continue to support it.
Were there ever any issues with the school districts about the time that would occupy the nurses doing this? It must be a little bit more time consuming than just seeing the child without all of the equipment and that sort of thing.
I haven't heard a word. I think they're excited about it. I mean, think about the extra training they're getting, the nurses.
The other question is, will you be able to provide a list of contacts for those of us who'd like to discuss this a little bit more, maybe with the folks up in Dallas?
Could I, if I could take Dr. Moore, just, have an exception, could I get Matt Moore with Children's Hospital of Dallas to stand up? And Matt, there you go. This is the guy. And that's what they're doing. They're working with other folks because they want to expand this concept and technology.
Yes, Representative
Yes,
Beth Robertson, and we all love, I think I'm telling what everyone, we loved hearing about your circuitous route that you had. And I have to say that if I'd only known we'd gone through the Education Committee for our Medicaid reimbursement, we'd have a lot more money to give for health care.
You know what I've learned?
Wow.
You only can do it once.
Okay.
And then they're on to you.
Well, we'll find another way. But,
but that's what I like. There's always a way.
There's always a way.
Always a way.
And really, the last question is very similar to mine. I was wondering about the scale, how much. It's mainly in Dallas, or do we have anything
well,
here
this is
in
where it
Houston
began. I think Texas Tech is doing some stuff too. Folks out there.
You know, in the day we tried this. This has got to be 15 years ago, but And it was so clumsy then because the technology wasn't ready.
Right,
But with
right.
the Houston group down in the valley doing things, but it really was not, it was before its time.
Well, see, this is why technology is just moving so fast, and what may be cost prohibitive or not practical today, tomorrow it will be. So that's why I got out of computers. It was moving too fast for me.
Well, thank you.
Hi, thank you very much. I'm Richard Ridge, Director of Nursing Innovation at Texas Children's Hospital, and I just wondered what type of collaboration, support, or partnership did you have with the Texas school nurses through the process prior to this, partnering with them at all? If you can just describe that a little bit.
With me, yeah, that would actually be through Children's Hospital, and I think they're working with that. I mean, I just got everybody on board for my legislation. I didn't want anybody opposing it, at least not publicly. So.
Representative, could you talk about how the parents respond to this type of care? I'm just sort of wondering, suppose a child, you said pink eye or asthma, so they need an antibiotic or a puffer. Do they eventually get that? And is there a way to include the parents in on the conference?
Yes, absolutely. The parents are given the option. Obviously when the child goes in, the nurse will call the parents. That's what they always do. They tell the parent that you have the option of, your child being treated through this service, and, they find out from the parent if the child has insurance. Well, I guess they might know, but let's say they have a child that comes in, doesn't have insurance, they can talk to the parent about that. They offer the parent the option of being in on the conversation, the call. And so while the parent isn't seeing all the video, they certainly are hearing everything that's going on. So the parent is very much, that is a big issue with me, that the parent is always front and center because it's their child. And they're given the report, for whatever, diagnoses and treatment is suggested. And the doctor can call in the prescription. The parent's told, they tell them probably which pharmacy is convenient. They can go pick up the child. They're also told if they think the parent needs to take the child to have further follow-up or treatment. So parent front and center, absolutely.
Several questions, I guess, maybe. Number one, does your legislation have some liability protection for the providers? Number two, what happens if you have a child that is not eligible for any of the state assistance, is not covered by insurance? And their parents are making $1 million a year, do they send a bill to the parents, or is this free to them? How's that work?
Okay, so the question is, remember the program began as a non-billable service. So this is what Children's is in the process of now, with their program, their service that they're offering, is setting up the billing rates. Now for the Medicaid, CHIP, as I said earlier, the compensation is pretty much the same as going to a doctor visit. The big savings is they're not going into the emergency room. And yes, the liabilities are the standard liabilities, and that's all written in the contract. Okay, thank y'all very much.
Well, we thank you all for coming, and we thank Representative Laubenberg for her wonderful and very interesting talk, and we hope to see you again. Thank you.